just to touch back to a point that you mentioned, like the use of, molecular subtyping. Again, I don't routinely order this as well because again, there's no action item right now at this point, right? But I mean, there is like the Moonrise One trial that's looking at erdafitinib, right, in this intravesical and the TAR 200 system. So something to kind of see that, maybe in the future we're going to be able to better characterize and even further subtype those patients. We already talked about how challenging it is that it's such a heterogeneous group. And I think over time with molecular subtyping, we'll probably get even more clarity over time. So I think that's a really exciting aspect of it. Just so we've touched on it, and I wanted to jump forward into kind of the unresponsive space. You already kind of mentioned some of the major players here. Adstiladrin is one of them. Anktiva is one of them. And, just recently TAR 200 came out in the unresponsive setting as well. And these are all kind of really great new new therapies based on some recent trials. Based on kind of the most recent data that's come out, walk me through some of those agents, and how do you kind of stratify and tell patients, well, I think you're a candidate for this drug and not this drug, or whatever it might be. It's a complicated space, and I think everyone's kind of looking for more clear guidance in this area.
Yeah, absolutely. I love talking to patients about this. So for me, I enjoy, going through all of these options, but it definitely makes patient counseling much more complex.
Yeah.
And it takes a lot to really walk the patient through all of this. I typically start my discussion kind of based on the order of approval, just because that's straightforward to me and how I frame it
Yeah,
in my mind.
that
So,
makes sense.
Gem-doce is an off-label treatment that's not FDA approved. It has retrospective data that supports it, and there are multiple multi-institutional cohorts which show that the 1 year recurrence-free survival in a mixed population of stages in BCG-unresponsive disease is somewhere between 60 to 70%, which is pretty high, with the
Yes.
big grain of salt that it's retrospective data. So I usually will offer that as my first kind of tidbit of evidence, pretty well tolerated. The main negative of Gem-doce is the logistic burden of having a patient have to be in the office for 2 separate installations.
Yeah.
Um, if you keep kind of moving forward through, which agents came out next, IV pembrolizumab, FDA approved in 2020, anytime complete response of 41% in a CIS BCG unresponsive population. When you look at the landmark 1 year complete response rate, which I like to look at just to try to compare apples to apples between all of these, it's less than 20%. And the grade 3 or greater toxicity rate is pretty high. It's somewhere between 11 to 13%, which is significant when you're considering the fact that these other intravesical therapies tend to be very low, 3% or
Sure.
less. So most patients are less interested in that option. I think if someone has really severe bladder spasticity issues or bladder capacity issues, that might be something interesting to that niche kind of situation. But for most patients, the risk-benefit profile isn't optimal for that. Next is Adstiladrin. This trial has a lot of great history to it. It was evaluated in MD Anderson. It's been in development for a
Right.
couple decades. They were one of the first trials that came out, so we learned a lot from their trial design. But their anytime complete response was a little bit higher, 53%. 1 year complete response rate for a pure CIS population was 24%, although it is quite a bit higher when you look at the pure papillary cohorts. So it's important
Right.
to have that distinction there. The major benefit of Adstiladrin is its ease of administration, both to the
Right.
urologist and to the patient. It's given quarterly, once every 3 months, which is really appealing for patients that don't want to have repeated intravesical installations or have trouble coming into the office.
Right.
So I think that's a nice option for some patients. Anktiva was most recently FDA approved. So this is an IL-15 superagonist. It's actually mixed right with the vial of BCG, and you give it
Yeah.
exactly like you give BCG, which is nice because patients and doctors are very familiar with that. Most of these patients are
Right.
BCG unresponsive, so they know all about BCG. And in their trial, again, they kind of learned from the prior trials. Their argument was this is an immunotherapy. It might take repeated exposure to the agent for it to work. So they did allow for reinduction
Hmm.
of Anktiva if there was persistent disease.
Yeah.
And including the reinductions, their 1 year complete response was 45%,
Yeah.
which is pretty good. Um, I think one kind of elephant in the room with that is that you need BCG in order to give the medication. And the
Yeah.
companies thankfully looking at bringing in new strains of BCG, recombinant BCG, so that we don't have to waste our precious BCG supply.
Yeah.
And we have a couple new promising agents and many clinical trials, but I think the two kind of forerunners are cretostimogene, that's an oncolytic adenovirus
Yeah.
that's given, similar 6 weekly induction like many other intravesical therapies. The Bond 3 study looked at cretostimogene monotherapy, and
Hmm.
they found that the anytime complete response was 75%, which is very impressive. And the
Right.
1 year complete response was, in the mid 40 percentile.
Yeah.
Um, and then we have TAR 200, which is the pretzel that we talked about before.
Right.
Also very promising data, anytime complete response of 82%, and the 1 year complete response again in kind of that mid 40, 40 to 50 percentile range. So the newer agents, the outcomes keep getting a little bit better.
Yeah.
Again, my philosophy, some of that might be because these agents are working better and better. Some of it might be because we're doing better surgery, we're getting rid of more CIS, and have better treatment pathways.
Yeah, I mean that's a great overview, Vignesh. And I think one of the I think the frustrating aspect, from a provider aspect is again, you know, all of these trials were based through single arm trials, right? And that's basically based on the FDA precedent they said when they approved pembrolizumab back in I think 2020. And they said, listen, I think this was going to spur innovation, and it did, right? It definitely brought more people to the table. It improved the the area of non-muscle invasive bladder cancer to say, listen, let's bring new therapies, and that's what we're doing. But I think one of the struggle here is there's no comparative arm, right? So we don't actually know if it's doing better than what a standard of care is, right? And we're using historical controls and whatnot, but it's not the same, right? And I think that's obviously a very frustrating aspect of this thing. But the other thing that really seems to be an overall trend in this area is the use of overlapping treatments, right? So, some of them is, Credo is now using maybe a PD-1 inhibitor or gemcitabine to see if there's any benefit in that regard. Some of them are using other PD-1 inhibitors. Sintilimab is used in one of the Sunrise trials.